Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observation and commentary on the Journal of Clinical Oncology article, New Cases of Acute Promyelocytic Leukemia Treated with Arsenic Trioxide and Their Long-Term Follow-Up by Kamran Alamogadam et al. My name is Richard Stone, and I am the Director of the Adult Leukemia Program at the Dana-Farber Cancer Institute, Harvard Medical School in Boston, Massachusetts. My oncologic specialty is leukemia and related disorders. My podcast title is Curing Leukemia with a Single Drug. The older classification system, known as the FAB system, and the newer WHO system subdivide patients with acute myeloid leukemia into 8 or more different subtypes. However, the vast majority of patients with AML, except for those above age 75, undergo an identical therapeutic approach, namely induction with an anthracycline plus cytarabine, followed by post-remission therapy with high-dose chemotherapy or allogeneic stem cell transplant. The latter choice depends on disease and host features. Moreover, except for subsets of mainly young patients who present with chromosomal translocations involving members of the core binding factor transcription factor family, AML is an intrinsically resistant disease. However, 10 to 15% of all adults with AML have acute promyelocytic leukemia, APL, an entity that is distinct pathophysiologically based on the translocation of the PML gene on chromosome 15 to the retinoic acid receptor alpha gene on chromosome 17, yielding a fusion product that prevents normal differentiation. The distinct presenting clinical manifestations include low white count, the absence of HLA-DR cell surface expression, and disseminated intravascular coagulopathy. APL not only has a distinct clinical presentation, but is highly responsive to therapy. Even before the discovery of all-trans-retinoic acid, clinicians realized that profound responses occur with an anthracycline alone, and patients achieved remission without bone marrow hypoplasia. The introduction of 2 long-standing Chinese remedies into the routine management of patients with APL has revolutionized the care of patients with this condition. First, the vitamin A analog, all-trans-retinoic acid, or ATRA, was shown to induce remissions even in advanced patients, albeit only transiently. However, when chemotherapy was added to all-trans-retinoic acid, long-term remissions were seen even without the use of cytarabine. Within the past decade, it has been further recognized that arsenic trioxide, a fairly well-tolerated drug administered intravenously, can produce high remission rates even in advanced APL patients with relapsed disease. Soon after arsenic trioxide was approved for treatment of relapse disease, a clinical trial was done, known as CLGB 9720, which showed that the use of arsenic trioxide early in the post-remission setting led to such positive results that the adverse risk attributed to high white count, greater than 10,000, at diagnosis became irrelevant. It did not take long for some investigators to test the notion that a chemotherapy-free approach might be successful in patients with acute promyelocytic leukemia. At MD Anderson Cancer Center, investigators evaluated the combination of all-trans-retinoic acid and arsenic trioxide to treat newly diagnosed patients with APL, at least those who were not considered fit for an anthracycline chemotherapy regimen. The durable response rate from this experience was high enough to lead to a UK trial that compares chemotherapy-based approach versus the MD Anderson regimen to determine if most patients with APL could avoid chemotherapy altogether. The authors of the present report from Iran have taken the notion of curing APL without cytotoxic chemotherapy one step further by treating patients with arsenic trioxide as a single agent. 197 patients were treated with arsenic trioxide daily until complete remission. The complete remission rate of 86% was as high as anyone could expect with a chemotherapy-based approach. A sizable fraction of patients died early due to differentiation syndrome, about 13%, which could be somewhat predicted by a high white count at diagnosis. After achieving remission, patients could receive 1 to 4 more courses of arsenic as consolidation therapy. 2/3 of the patients were free of disease at 5 years, a remarkable result with a single agent. Thus, single-agent arsenic trioxide may be a viable therapeutic strategy in patients with acute promyelocytic leukemia. However, at this time, it is inappropriate to treat a patient with arsenic trioxide alone. First, as previously mentioned, the combination of ATRA plus arsenic can lead to a high rate of long-term survivors, as shown by the MD Anderson group. It should be noted that in the MD Anderson study, using this combination, gemtuzumab ozogamicin, no longer commercially available, was added if the white count was elevated at diagnosis or during therapy. Secondly, the precise reason for giving a patient a certain number of courses of arsenic consolidation is unclear from this report. Perhaps more aggressive treatment or better supportive care could have decreased the relatively high mortality rate due to the differentiation syndrome. In summary, this report by Dr. Al-Imaghaddam et al. Shows that a treatment born of tradition and necessity can frequently produce long-lasting remissions in patients with APL. By Western standards, the results might not be considered optimal because the 5-year survival rate of 64% has been exceeded by other recent reports of therapy for newly diagnosed APL patients. However, from a global health standpoint, the ability to cure patients with an otherwise deadly disease in a cost-effective manner is admirable. Trials are ongoing now to determine if non-chemotherapy treatment with ATRA plus arsenic trioxide is equivalent to the use of these drugs in combination with cytotoxic chemotherapy. Should the results indicate that the non-chemotherapy approach is as good or better than more traditional chemotherapy-containing regimens, then it might be appropriate to test ATRA plus arsenic versus arsenic alone, as detailed in the report in this issue of JCO. Finally, I would like to comment on the geopolitical implications of this study. When these investigators were asked to present their data at a major U.S. national meeting, they were unable to do so due to government-imposed travel restrictions. This report is a testament to the author's determination to share knowledge about therapy that can benefit patients regardless of political conditions. This JCO publication serves to remind colleagues worldwide that the physician's duty is to provide the best patient care possible, transcending local laws and political or geographic boundaries. This concludes the JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.